Hey everyone, welcome to this explainer. Today, we are diving straight into the fascinating world of modern pharmacology to see exactly how medicine uses highly targeted medications to suppress some of our absolute toughest viral enemies. We're talking about major systemic threats here, like herpes, cytomegalovirus or CMV, influenza, and HIV. If you've ever found yourself wondering how modern science manages to keep these incredibly complex, rapidly mutating viruses in check without completely wrecking the host's body, well, you are in the perfect place.
Okay, let's jump right in. If you remember absolutely nothing else from this explainer, remember this foundational golden rule. Antivirals do not cure infections, they suppress replication. Seriously, this is a massive paradigm shift you need to make when you're thinking about antivirals compared to, say, your traditional antibiotics. We aren't sending in a tactical squad to completely wipe out the invader. Instead, we're essentially throwing a wrench into the virus's machinery. We pause its replication, stop it from multiplying, and ultimately we give the host's own immune system the upper hand and the crucial time it needs to fight back. Here's our roadmap for today. First, we'll cover the golden rule of antivirals, then we'll look at anti-herpes agents, anti-CMV agents, anti-influenza agents, and finally, antiretrovirals for HIV.
Starting right off with Section 1, the golden rule of antivirals. So understanding these three core principles is basically your baseline for almost all antiviral classes. Remember, these biological task forces are designed for suppression, not total eradication. Step 1 is you have to start treatment early. Because viruses hijack our own cells to replicate exponentially, the sooner we intervene with a suppressor, the better the clinical outcome is going to be. Step 2 is monitoring renal and hepatic function. These drugs rely really heavily on the kidneys and liver for processing and clearance, and they can be incredibly tough on those organs. And step 3 is educating on adherence and transmission prevention. Since we're suppressing the virus and not curing it, keeping drug levels perfectly steady in the bloodstream is an absolute daily priority to maintain that suppression and prevent spreading it to others. Moving right along to Section 2, anti-herpes agents. Here we're dealing with specialized agents used primarily for managing conditions like genital herpes and shingles. So the crucial point is grasping the subtle but really important differences between these medications. First step, we have acyclovir, or Zovirax. This is our versatile baseline because it can be given via IV, oral, or topical administration. Then we have valacyclovir, or Valtrex, which is actually a prodrug of acyclovir, meaning it physically converts into acyclovir once it's inside the body. The huge rule of contrast here is that valacyclovir has significantly better oral absorption. And what does that mean for your patient? It means much less frequent dosing and a schedule that is just way easier to stick to compared to oral acyclovir. Lastly, we have famciclovir, which functions similarly but is specifically noted for being highly effective against shingles. But we really need to talk about what happens when a patient requires IV acyclovir for severe systemic infection because it tells a critical clinical story. IV acyclovir requires hydration to prevent nephrotoxicity. Because this particular drug is notoriously rough on the kidneys and can literally crystallize in the renal tubules as it's being cleared out, nurses have to proactively and heavily hydrate the patient with fluids during and after the infusion. It's a direct cause and effect intervention designed to flush those kidneys and protect their renal function.
All right, on to Section 3, anti-CMV agents.
Cytomegalovirus, or CMV, is no joke. It's a dangerous infection that severely targets immunocompromised patients, like those living with advanced AIDS or folks who have had organ transplants. The agents we use here are incredibly serious medications for serious situations. You absolutely do not use these for mild infections. We use ganciclovir via IV specifically for severe conditions like CMV retinitis, which can actually cause rapidly progressing blindness. There's also valganciclovir, which is an oral prodrug option for maintenance. And crucially, strict hand hygiene isn't just a suggestion here, it is a mandatory nursing protocol. These drugs have elements of cytotoxicity, meaning they're incredibly potent, and require the absolute strictest handling and hygiene protocols to protect both the highly vulnerable patient from secondary infections and the healthcare worker actually preparing the medication. And honestly, here is exactly why these drugs require such careful, specialized management. The physiological toll of anti-CMV agents includes a very high risk of myelosuppression. Basically, this means the drug suppresses the activity of the bone marrow itself, severely dropping the patient's white and red blood cell counts. Because of this, strict, ongoing monitoring of a complete blood count, or CBC, checking specifically for neutropenia, which is low white cells, and anemia, is absolutely essential during the entire therapy. Let's shift gears to Section 4, anti-influenza agents.
Influenza is a ubiquitous, everyday viral target, right? But with the flu, the success of the treatment is completely dictated by the delivery methods chosen and incredibly strict timing. And this brilliantly illustrates how vital it is to choose the right delivery method for the right patient. First, we have oseltamivir, which most of us know as Tamiflu, our standard oral option. But contrast that with zanamivir, or Relenza, which is actually delivered via an inhaled discaler. The direct danger here is for patients with underlying respiratory issues. If you have a patient with asthma or COPD, inhaling a medicinal powder can immediately trigger severe bronchospasm. So you have to exercise extreme caution or just completely avoid zanamivir for those respiratory populations.
48 hours. Whether you are prescribing Tamiflu or Relenza, this right here is your magic clinical window. To actually halt viral replication in any meaningful way, these anti-influenza medications absolutely must be started within 48 hours of symptom onset. If you start them on day 4 or 5, the virus has already replicated to its absolute peak levels, and the medication isn't going to have any real clinical impact. With the flu, timing is literally everything.
Finally, Section 5, Antiretrovirals for HIV. HIV is easily our most complex viral target, requiring life-saving, heavily coordinated heavy-hitter medications to fight off an incredibly stubborn, adaptive virus. The entire foundation of this battle is HAART, which stands for Highly Active Antiretroviral Therapy. This is the gold standard combination therapy used to fiercely suppress the viral load down to completely undetectable levels. The strategic logic behind this is honestly brilliant. HIV mutates rapidly, right? If you hit it with just one drug, it will easily mutate around it and become resistant. But by using HAART, where we administer multiple drugs from different classes at the exact same time, you trap the virus. You completely overwhelm its ability to mutate, and you prevent drug resistance before it even has a chance to start. Now, what's really fascinating about this slide is unpacking these distinct HIV drug classes and their highly specific and often very memorable side effects. First up, NRTIs, like zidovudine or AZT. These are notorious for mitochondrial toxicity, which can lead to lactic acidosis, anemia, and bone density loss. Next, NNRTIs, like efavirenz. Now, these can cause standard rashes, but very uniquely, they cause profound CNS effects like incredibly vivid dreams, alongside liver toxicity. Then we have protease inhibitors, like ritonavir, which is actually often used as a booster for other drugs. These come with intense metabolic side effects: lipodystrophy, which is an abnormal redistribution of body fat, hyperglycemia, and a massive host of CYP450 enzyme interactions, meaning they heavily alter exactly how other drugs are metabolized in the liver. It is a wildly complex pharmacological balancing act. To finish rounding out our antiretroviral toolkit, we also have integrase inhibitors, like raltegravir, which our sources note are generally very well tolerated with much fewer drug interactions. And entry inhibitors, like enfuvirtide, which is highly unique because it's actually an injectable fusion inhibitor. It stops the virus from even entering the cell in the first place. Which brings us to the ultimate nursing priority. We have to repeatedly return to our golden rule. Strict, unwavering adherence is absolutely critical. Because we are only suppressing, not curing. If a patient misses even a few doses, that viral load spikes and irreversible drug resistance develops incredibly fast. Strict adherence isn't just a casual clinical suggestion. It is the absolute cornerstone of long-term patient survival. So this actually brings us to a really crucial final thought to wrap up this explainer. With viral suppression relying so heavily on perfectly strict adherence, how can we better support patients who are taking lifelong therapies like HART? It's this incredibly vital intersection between complex pharmacology and human behavior. Science has absolutely given us the chemical tools to suppress the viral threat, but it's human support, comprehensive education, and genuine clinical empathy that ensure those tools actually work over a lifetime. Thanks so much for joining me for this explainer, and keep exploring these amazing medical advancements.